Hi, this is Kent Johnson from Rocky Mountain University of Health Professions, and this is my case presentation on the knee and my patient's return to sport. The patient was a 19-year-old female. She was a collegiate student and a basketball player who was originally examined on the 29th of March with the diagnosis of a sprain of the ACL. Currently, she is seeking care following a surgical debridement of the ACL in the left knee, which she injured while playing basketball the past December. So like I said, she was injured in December of 2012, but then she had just recently undergone surgery on the 28th of March. Her initial photo score was a 15 with a predicted change of 44 over 58 days or 16 visits. So her knee pain specifically, she was in the anterior knee. She reported as constant, deep, and throbbing pain. Currently it was rated as 5 out of 10, and at that time that was the best it had felt. But at the worst it would get up to a 7 out of 10. And there was no numbness or tingling reported at the initial examination. These are the structures which can also be considered a source of symptoms at the knee. I'll give you a little time to look at those quick. So my primary hypothesis at this time was anterior knee pain secondary to the ACL debridement surgery, but some competing diagnoses could also be patellofemoral pain, and then some of the red flag things such as infection or a DVT. The current aggravating factors were any active range of motion, as well as any positional changes and some light weight bearing. Pain with any of those activities came on within seconds, but would later relieve after several minutes of rest. The only thing she could really do to ease the pain was rice and taking Loratab for pain control. The night before, following the surgery, she had woke several times just due to the pain, but she was able to relieve that pain with some positional changes as well as the medication. So her current symptoms have actually been present for the past 3.5 months, just the knee pain specifically. She injured it while in a basketball game. She reported she was jumping for a rebound, and when she came down, she landed awkwardly. So since that time, she had actually underwent some conservative care, gone through physical therapy, and then just rested from basketball for about a month. She then tried to return for 2 weeks before discontinuing that at that time because of increased pain and swelling that was coming along with playing basketball. An MRI did find a partial tear of the ACL, but they really weren't sure how significant or severe it was. So while undergoing arthroscopic surgery, they really just found a small tear, which he was able to debride, and at the time he left it, he reported the ACL was still 90% intact. No real significant medical history in their past, but up to that time before surgery, she actually wasn't able to fully straighten her knee, so she lacked normal extension, which is something we wanted to monitor following surgery. And kind of like I said before, her previous treatment was just about a month long of conservative PT to improve the quad control and dynamic stability at that time. So as far as her subjective reports go, her red flag screen was clear of any fever, night sweats, chills, anything like that, as well as her yellow flag screen was unremarkable as well. The MRI that she had undergone did show the partial tear on the left ACL, and she was currently taking Loratab, had been taking naproxen, but since the surgery was no longer taking this. So the asterisk signs we're going to use from her history would be the resting pain of 5 out of 10, as well as the increasing pain to 7 out of 10 with the knee range of motion. So we'd be looking for that motion to improve before any of her pain is increased, and as well as a subjective report of her pain increasing or changing with positional changes. So our primary hypothesis at this time remains knee pain secondary to the ACL debridement surgery. We pretty confidently can rule out patellofemoral pain just due to the physician notes with the MRI and the surgical history. we feel pretty confident about what is causing her pain. But as far as subjectively, really non-musculoskeletal things such as red flag findings, really can't confidently rule anything out until a further objective exam. The severity of the condition at this time I would consider to be moderate. She does have quite a bit of pain that comes along with any really activity. It limits her function and ADLs quite a bit at this time, as she's not able to weight bear or change positions very easily. So all those things considered makes this a moderately severe condition. The irritability would also be moderate, just due to the fact that she doesn't really tolerate any kind of change in movements or any weight. These bring on her symptoms pretty quickly within a couple seconds, and then it takes a couple minutes of rest before those resolve. So as far as the primary nature of this problem, her knee pain itself would be musculoskeletal, and the reason she had surgery would be musculoskeletal. But her current complaints and her current pain would actually be more of an inflammatory process following the surgery. The stage of the disorder at this time would actually be in its worst stage, just due to the recent surgery. She's actually experiencing more pain and probably has a little more swelling than she had really ever had in the past. And this would also be considered to be in the acute inflammatory healing stage at this time as well. The current stability disorder is also stable and reproducible because her symptoms are brought on with all the asterisk signs. So as far as things we want to include in our objective exam, a couple of the main things would be a little more palpation to certain areas of the leg, as well as inspecting the wound for color or certain drainage changes, as well as just a general observation of the whole leg and knee itself, just looking for anything out of the ordinary that would clue us into maybe more of a red flag. And then as far as things to defer, one main one would be the manual muscle testing. At this time it doesn't really make sense due to her irritability to be pushing and pulling on things that are just going to make her sore and are probably going to test weak because of the pain at this time anyways. A couple other things would also be some of the return to sport testing, as well as the integrity of the ACL, as far as the ligament test as well. Those things will all be pushed back into when she's more pain-free, and I actually talk a lot about those things more in the second part of my presentation. As far as precautions went with this patient, her weight-bearing status was really actually weight-bearing as tolerated. She came in using crutches, favoring the right leg, keeping most of her weight off the left, but as soon as she was able to, she was instructed to put more weight through the left leg. She had a normal postural observation. And for her functional movement analysis, later on in the process, we would perform a functional movement screen, something I talk a lot more about in part 2, but we weren't able to do this until she was pain-free and also had normal motion. We did a quick screening test of the hip and lumbar spine in the seated position, and those checked out pretty clearly, and it wasn't something that was reproducing her knee pain. She also had a normal neuro exam. For her range of motion in her left knee, actively she was only able to get 3 degrees of, she was lacking 3 degrees of extension, and also was able to do 82 degrees of flexion on her own. Passively, these both improved to normal extension or 0 degrees, and 112 degrees of flexion. That 0 degrees of extension she was able to get was actually better than she even had prior to surgery, so that was a good sign. But both of these end ranges increased her pain to that 7 out of 10. So we did a little more palpation, more to check the swelling and edema in her knee, which we found it increased her pain just due to the soreness of the area, but there was no pitting edema present. Like I said, we deferred manual muscle testing as well as muscle length testing because she did not have full motion at this time. And her motor control at the quad, it wasn't great. I mean, you could feel it activating with during isometric quad sets, and she was also able to lift her heel about an inch during the short arc quad, and then with a straight leg raise, there was still a moderate amount of lag in the lower leg while performing that exercise. So our primary hypothesis at this time would continue to be the knee pain secondary to the ACL debridement surgery, as we were able to clear really through the rest of our objective exam any red flag findings. And so that made us pretty confident that her pain was just due to the surgery itself. As far as the historical and physical exam asterisk items we'll be using will be the pain at rest, as well as her pain with motion and how far into that motion we can go before that pain returns, and then just her overall tolerance and the pain that comes with positional changes or weight bearing. From the physical exam, we'll be really monitoring her range of motion early on, trying to improve that to normal as quickly as possible, monitoring and looking at her quad activation, as well as decreasing her swelling as soon as possible. So for the prognosis of this patient, we do expect her to have a full recovery to her previous level of functioning. We expect this to occur over the time of about 12 to 14 weeks, due to the fact that she's not an ACL reconstruction. We would likely treat her as one, but it will just be in a quicker fashion. We'll likely see her initially 2 times a week for a majority of that time frame, likely going down to once a week if she is showing good independence in her home exercise program. As far as our goals and her goals for physical therapy, we both wanted her to return to full speed and contact basketball activities, and following play, we don't want to see any residual swelling or pain occurring. If she's not making progress, it would be likely that we would contact her physician if after a couple weeks things just don't seem to be going the way we'd like them to. There's more pain and swelling than we would expect. We do have the luxury of working at a orthopedic center where the physicians are on the same at the same facility as we are, and so when they see their physician, they'll usually see us at the same time, or at least the same day, and we normally stay in close contact. So that is nice, and it would be more likely that we would contact him then too if things weren't going the way we'd like them to. The management strategy with her and with a lot of patients such as this are broken up into a couple different areas. The first thing we'd like to do is decrease pain and swelling while getting him range of motion back to normal as soon as possible. And soon after there, looking at more of the quad activation and just the overall strengthening of the lower extremities and core. And then moving into more closed chain activities and increasing the stability of the knee itself. Thanks for listening, guys. If you have any questions, feel free to post in the forum. Nothing else, we will talk to you on Thursday. Thanks.